Hello everyone. Now I will discuss question of neurology. Well, we have a 50-year-old lady. She's brought to the emergency department when she suddenly developed weakness in right upper and lower limb while she was jogging on a treadmill. Her weakness gradually worsened over the next hour and she has severe headache and now started developing experience nausea and vomiting also. The patient has a history of chronic hypertension but stopped taking antihypertensive about a months ago. She's tired of taking medicine and tried to cure herself with exercise. She doesn't use tobacco but drinks 1 to 2 glasses of wine on weekends. Her BP is still very high, 174, 102, pulse normal. On neurological examination, she has right hemiplegia, right hemisensory loss, and left ward deviation of the eyes. Which of the following is the most likely diagnosis? Well, the answer is this is Putamen bleed. This patient has hypertensive intraparenchymal brain hemorrhage. Well, she's a chronic hypertensive. She is not taking any medicine, and right now also she has high BP. Now, this hypertensive bleed, it typically comes as a focal neurological deficit. That means this is a feature of all stroke. Little bit basic concept. Stroke means anything vascular event. In neurology, anything sudden onset is of vascular etiology unless proved otherwise. In this case, suddenly 2 hours back, she was jogging on the treadmill and she developed right hemiplegia. And gradually worsened over a minute to hours. Symptoms often occur during routine activity but may be precipitated by exertion, jogging on treadmill like our patient was jogging. That really exertion precipitated hemorrhage. Well, when the bleeding is occurring, that leads to raised ICP. Intracranial pressure goes high and that leads to headache, vomiting like in our case also. Patient starting having severe headache, nausea, vomiting, seizures and altered mental sensorium not developed yet, but they can develop especially when the bleeding is like this. Okay. Now, when we talk about hypertensive bleed, hypertensive hemorrhage, the common site are basal ganglia, especially the putamen, cerebellum nuclei or cerebellum, thalamus and pons. They are the classical four sites where the hypertensive bleed can occur. Of course, intraparenchymal or parenchymal bleed is different, is fifth one also. But they are the four, and after this is the most common and most important. Well, putamen bleed is due to almost always involve adjacent internal capsule. What is this? Let's learn the basic concept. This is the internal capsule. This is the posterior limb. Posterior limb, this is the anterior limb, and this is the corticospinal tract. And these are the sensory fiber in the very rough, a very line diagram. Sensory fiber means so-called corticothalamic tract. Here lies the putamen. When the bleeding occurs in putamen, it really goes into nearby putamen also, in the internal capsule also. The bleeding occurs in putamen. Okay, this is the putamen, but it spreads to the posterior limb of internal capsule. That's why in this case also there is motor problem and the sensory problem, because the blood has come from putamen to internal capsule. So it always involves the adjacent internal capsule. This leads to contralateral hemiparesis and hemianesthesia, and this is all due to disruption in the posterior limb, as I explained to you in the diagram also. Now, what type of gaze deviation occurs in bleeding in putamen? Well, in the right putamen hemorrhage, conjugate eye deviation to the side of lesion, like in our case also. Remember, there was contralateral hemiplegia, right-headed, but the bleeding occur in the left side, so it will in the same side. That means eyes will be looking toward the lesion, left side to be more precise. Whatever side is, like in our case, in our patient, it will be on the left side because the lesion is in the left side. It is due to damage to frontal eye field efferent in the anterior limb, and pupils are normal in size and they normal in reaction. Okay, normal in size, normal in reaction. Now let's talk about cerebellar hemorrhage. They present with occipital headache, nausea, vomiting, dizziness, and cerebellar sign like ataxia. Definitely. Usually no hemiparesis because cerebellum is not concerned with motor activity. It's concerned with balance, so hemiparesis is not a problem. Early diagnosis is very essential. Now comes the question, why emergency decompression may be life-saving in these patients? Quickly write down the answer, stop the video. Okay. Well, it's very essential to diagnose and treat very easily. Well, this is the brain, this is the spinal cord, this is the vertebra, and here lies the cerebellum. When raised ICP occurs, and posterior fossa is a very close chamber, due to raised ICP, this cerebellum tonsil may cone down, and they will have a arrest immediately. They will have spinal cord compression and patient will die immediately. So it is very essential to diagnose very early so that we can do the decompression which may be life-saving. Now one more thing, in the previous slide I told you there are 4 important signs of bleeding. Hypertensive bleed, putamen, thalamus, pons and cerebellum. Out of these 4, the only place where we can actually can operate is cerebellar bleed. Why? It is a posterior fossa, we can make a cut and we can drain out the blood. Rest all, putamen and pons, thalamus, these are deep inside bleeding, so not possible to do surgery, but this we can do surgery and we can save the patient very easily. Well, the next option is pontine hemorrhage. It causes contralateral hemiparesis, contralateral hemianesthesia, and pinpoint pupil. This is a classical finding that we get in these patients. This patient headache worsen is more consistent with the hemorrhage, sudden neurological deficit, than gradually. Okay, so findings are not consistent with pontine hemorrhage. Lobar hemorrhage typically occurs in adult over 60 years due to amyloid angiopathy. Hemorrhage tend to be recurrent and most often involve the occipital or parietal lobe. Occipital lobe hemorrhage may cause homonymous hemianopia. Parietal lobe causes contralateral hemisensory loss. Hemisensory loss because all the sensation they go to contralateral parietal lobe. Option D, medial medullary syndrome infarction is incorrect. This is due to occlusion of branch of vertebral artery. The patient has contralateral paralysis of the arm and leg. This is due to involvement of lateral corticospinal tract. Contralateral loss of position vibration sense because there is a dorsal column or medial lemniscus, and tongue deviate to the side of lesion because the hypoglossal nerve is involved. Let me make a picture for you. This is the corticospinal tract, so-called pyramidal tract. This is the 12th nerve. This is the medial lemniscus. Well, I hope you know this. They contain the dorsal column. They are what we have dorsal column in spinal cord. They contain position, vibration sense. Now this part of the brain is supplied by branch of vertebral artery. So when this lesion occurs, there will be ipsilateral 12th nerve palsy, ipsilateral 12th nerve palsy, contralateral hemiplegia, and there will be contralateral loss of position, vibration sense. That is the basic diagram to know about medial medullary syndrome. So to give a summary, ipsilateral 12th nerve palsy, and remember the tongue will deviate to same side of lesion. Hemiplegia, sparing of the face, hemianesthesia, sparing of the face. Golden line to remember, basal ganglia putamen is a common site of hypertensive intraparenchymal brain hemorrhage. The internal capsule that lies adjacent to putamen is almost always involved. This leads to contralateral sensory loss, contralateral hemiparesis, contralateral gaze deviation, that is toward the side of lesion. That is, you can say gaze is deviated toward the size of lesion. Okay, that means hemiparesis is occurring on one side and the deviation of eye is occurring to other side. Thank you very much.